Welcome back to Audioboards. Today we're covering Takotsubo Syndrome, also known as stress cardiomyopathy, broken heart syndrome, or Takotsubo cardiomyopathy. This is one of the most fascinating conditions in cardiovascular medicine because it looks almost exactly like an acute myocardial infarction. Yet the underlying mechanism is completely different. Patients can present with chest pain, ECG changes, elevated troponins, heart failure, cardiogenic shock, and even ventricular arrhythmias, but when coronary angiography is performed, there is often no culprit coronary occlusion. The hallmark is transient left ventricular dysfunction that usually recovers over days to weeks. The challenge is that during the initial presentation, you cannot safely assume it's Takotsubo syndrome. Every patient must initially be managed as a possible acute coronary syndrome until proven otherwise.
So the first lesson is that Takotsubo is usually diagnosed after we've ruled out a heart attack.
Exactly. The diagnosis is often made retrospectively after imaging and coronary evaluation. Most patients present with symptoms indistinguishable from ACS. They have chest pain, dyspnea, ECG abnormalities, and elevated cardiac biomarkers. In fact, approximately 1 to 3% of patients presenting with suspected ACS ultimately have Takotsubo syndrome, and the proportion is higher among women. Postmenopausal women account for the vast majority of cases. The classic trigger is intense emotional stress, death of a loved one, divorce, financial crisis, or severe fear. But physical stresses are actually very common. Sepsis, stroke, surgery, trauma, asthma exacerbations, cancer, and other acute illnesses can all precipitate Takotsubo syndrome. The prevailing theory is a catecholamine surge causing myocardial stunning and transient ventricular dysfunction. Now, let's talk about diagnosis, because understanding the diagnosis helps guide management. When Takotsubo is suspected, start with the same evaluation you'd perform for ACS: ECG, serial troponins, BNP or NT-proBNP, chest imaging, echocardiography, and usually coronary angiography. The ECG may show ST elevations, ST depressions, T-wave inversions, or QT prolongation. Troponin is usually elevated, but often appears disproportionately low relative to the extensive wall motion abnormalities seen on echocardiography. BNP levels are often substantially elevated. The echocardiogram is critical. The classic finding is apical ballooning with hypercontractile basal segments, but several variants exist, including midventricular, basal or reverse Takotsubo, and focal variants. Importantly, the wall motion abnormality extends beyond the territory of a single coronary artery.
And coronary angiography is usually required?
Yes, most patients with ST elevation or suspected ACS undergo urgent coronary angiography. Demonstrating the absence of an acute culprit coronary occlusion is a key component of the diagnosis. Remember that some patients may still have underlying coronary artery disease. The diagnosis is not excluded simply because coronary disease exists. What matters is the absence of an acute coronary lesion explaining the ventricular dysfunction. Now let's move into management, which is where most clinicians have questions. The first principle is that there is no disease-specific therapy proven in randomized clinical trials. Management is largely supportive and directed toward the patient's hemodynamic status and complications. During the acute phase, treat the patient as ACS until the diagnosis is clarified. This means aspirin, anticoagulation when appropriate, urgent cardiology evaluation, and reperfusion assessment if STEMI is suspected. Once Takotsubo syndrome is confirmed, management shifts toward heart failure care and complication prevention. For the stable patient with reduced left ventricular ejection fraction, guideline-directed heart failure therapies are commonly used. CE inhibitors or ARBs are generally favored because observational studies suggest improved outcomes and potentially improved survival. Beta blockers are commonly prescribed as well, particularly when sympathetic activation appears prominent, although evidence that they prevent recurrence is inconsistent.
So in a typical uncomplicated patient, you may see treatment with an ACE inhibitor or ARB, a beta blocker, diuretics if congestion is present, and close follow-up imaging. Okay, now what about anticoagulation?
Excellent question. Severe apical akinesis can lead to left ventricular thrombus formation and systemic embolization. If a ventricular thrombus is identified, anticoagulation is indicated. Many experts also consider anticoagulation in patients with severe apical ballooning and markedly reduced ejection fraction, particularly if thrombus risk appears high. Therapy is typically continued until ventricular function recovers and repeat imaging confirms thrombus resolution if one was present. Now let's discuss one of the most important management concepts in Takotsubo syndrome, determining whether left ventricular outflow tract obstruction, or LVOTO, is present. Patients with Takotsubo can develop dynamic LVOTO due to hypercontractile basal segments and systolic anterior motion of the mitral valve. This distinction completely changes management. If the patient is hypotensive or in shock, an urgent echocardiogram is essential to determine whether LVOTO exists. If shock occurs without LVOTO, management resembles treatment of severe heart failure. Vasopressors, inotropes, mechanical circulatory support, and advanced heart failure therapies may be necessary depending on severity. However, if shock occurs with LVOTO, traditional inotropes can actually worsen the obstruction and make the patient deteriorate. In these patients, management focuses on volume resuscitation when appropriate, beta blockade, and avoidance of medications that increase contractility.
So, echocardiography isn't just diagnostic, it directly guides therapy.
Exactly. In Takotsubo syndrome, knowing whether LVOTO is present can be life-saving. Let's talk about complications. Many people think Takotsubo is benign because ventricular function usually recovers, but the acute phase can be dangerous. Complications include acute heart failure, pulmonary edema, cardiogenic shock, ventricular arrhythmias, atrial fibrillation, thromboembolism, ventricular rupture in rare cases, and sudden cardiac death. Major complications occur in roughly 5 to 10% of patients. Patients with significant ventricular dysfunction should be monitored on telemetry. QT prolongation is common and may predispose to torsades de pointes, so electrolyte abnormalities should be corrected aggressively and QT prolonging medications avoided whenever possible. Another important point is that recovery is expected. Repeat echocardiography is a cornerstone of follow-up. Most patients experience substantial improvement within days to weeks, and many normalize ventricular function within several weeks. Persistent severe dysfunction months later should prompt reconsideration of the diagnosis.
What do you tell patients about recurrence?
Recurrence can occur, although it is relatively uncommon. Unfortunately, no therapy has definitively been proven to prevent recurrence. Beta blockers are often continued because of the catecholamine hypothesis, but evidence remains mixed. Risk factor modification, management of anxiety or emotional stressors when appropriate, and optimization of cardiovascular health are all reasonable strategies. Now let's summarize the practical management approach. A patient presents with chest pain and elevated troponin. Manage initially as ACS. Obtain ECGs, biomarkers, echocardiography, and usually coronary angiography. Confirm the diagnosis by identifying characteristic ventricular dysfunction without an acute culprit coronary lesion. Assess for complications immediately, especially heart failure, arrhythmias, ventricular thrombus, and cardiogenic shock. If stable, treat supportively with heart failure therapies such as ACE inhibitors or ARBs, beta blockers, and diuretics when needed. Evaluate carefully for LV outflow tract obstruction because it dramatically changes shock management. Anticoagulate when ventricular thrombus is present, and consider it in selected high-risk patients with severe apical ballooning. Monitor closely during the acute phase because complications can be serious despite the syndrome's reversible nature. Repeat echocardiography to document recovery. And finally, remember the key teaching pearl. Takotsubo syndrome may be reversible, but it is not benign. Early recognition, thoughtful hemodynamic assessment, and careful management of complications are what determine outcomes.
So, the big picture is that Takotsubo syndrome is a transient cardiomyopathy that masquerades as myocardial infarction, requires initial ACS management, relies heavily on echocardiography for risk stratification, and is treated primarily with supportive heart failure therapy while watching closely for complications.
Exactly. If you remember nothing else, remember this. Treat first like ACS, confirm the diagnosis, assess for LVOTO and complications, support the patient through the acute phase, and verify recovery with follow-up imaging. That's the practical framework for managing Takotsubo syndrome. And that's today's Audioboards masterclass on Takotsubo syndrome management. Thanks for listening to Audioboards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the Audioboards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified board-certified healthcare provider for any medical concern.